Okay, this lecture is on vision and perception, and this is from our Carlton book. You have several objectives that you need to be able to draw, explain, discuss, describe and state, apply, identify. So there's quite a few that you need to be able to answer. So the back of your book questions should help you with all of that. So let's talk first about image perception. So misperceptions can be dangerous in radiology. So if a radiologist misses something due to misperceptions, it's a big deal, okay? So we eliminate preconceived ideas about an image to overcome these misperceptions, okay? Radiologists have extensive training and education to lessen the likelihood of misperceptions on images, okay? And radiographers should seek to better understand the perceptual challenges encountered by radiologists and what they do, okay? So if we take a look here and we look at this image, do you see a vase or do you see two faces? So this is one of those where something can look like something else. So if we look, we have the vase where this white is the vase. So you can see there's the lip right here, and then we have the bowl part right here and the stem with the base right here. Now, if we look over here, it's a face. So it comes down, here's a forehead, a nose, lips, and a chin, and it comes down to the neck. So it's on both sides. So kind of looking, it can be multiple things, right? So here's another one. This is another famous picture that people can see two different things. So if you see a young woman versus an old lady, those are the two images that are here. So if you look, here is the hair of the young woman with the feather, and here's her eyelashes, her nose, it comes down to her chin, and this is her ramus right here. So her body and ramus, here's her ear, and she's got a scarf on. So here's her eye, her nose, her chin, it comes around, here's her ear. Now if we look at it and say, okay, the old lady, so we've got her hair and we've got her eye, it comes down, here's her nose, and then it comes down, here's her mouth, and here's her chin. And then she's got a scarf on also. So two different images within one, okay? And this is what the radiologists face every day. So let's look at the anatomy of the human eye, okay? So if we see here, this is the whole globe, okay? So we have the retina, comes all the way around with the optic nerve, and then we have what's called rods and cones, okay? We're going to talk a little bit about rods and cones because they're important with our how much light we're dealing with on detail, okay? So we have our cones on the outside and our rods here concentrated in one little area. So this is the fovea right here, you see it right there, and we've got our lens. This is vitreous humor or aqueous humor, either one. Here's your cornea, iris, pupus, and you have aqueous humor right here. So vitreous and aqueous. So it's important that you know where the rods and the cones are, okay, within the retina. So the aqueous humor, the cornea, the iris, and the lens, they gather and they focus the light, okay? The retina cells transform light to nerve signals. So the retina takes the light that's coming in and takes it and puts it into nerve impulses for the brain, okay? So what does this is the rods and the cones, and the optic nerve transmits these signals to the brain, these nerve impulses to the brain. So visual correction, so the cornea malformations cause improper focusing of light on the retina layer. So there's different kinds. There's myopia, hyperopia, and presbyopia. So corrective lenses focus light into the fova centralis for highest visual acuity. So visual physiology, conversions and processing problems. So unsure if causes originate from the light sensitive cells or trouble with neurological processing, so mental misperceptions. Okay, so they're not sure exactly where the problem is. So let's talk a little bit about rods and cones. They emit those neural pulses when stimulated by light that go to the brain through the optic nerve, okay? More rods than cones. So cones primarily are located within the fova centralis of the retina. So rods convert the rest of the retina. So controlled by cones. So let's look at our photopic vision, and that is our cones, okay? Located at the fova centralis, contains 1 out of 3 light-sensitive pigments, requires bright light to function, and it permits greater density difference recognitions and permits greater contrast perception. So those are all good things, right? So visual acuity, highest concentration of cones at the fova centralis results in sharp daylight vision. So poor peripheral vision due to lack of cones in the rest of the retina. So you can't see well on the sides, but you can straight ahead, okay? So cones detect changes in brightness. So improved contrast perception. So the idea that there's changes in the contrast is what we're looking at here, okay? So scotopic, which is our rod vision, that's our night vision. So scotopic, rod, night. So sensitive to low light, can generate neurologic impulses when struck by as few as 15 light photons. That's very, very small, so it's very sensitive to night vision. To light, I should say. So we're still on rods, so scotopic can't function in bright lights. So rhodopsin is what is released and it bleaches out with high light levels. So what happens is you need to go into a dark room and you need to wait for the light. Okay, you need to wait for the light to go down. You have to let your eyes adjust. And then when you walk from a dark room into bright light, you get where you can't see. It's super bright, okay? So it can't distinguish light wavelengths, but most sensitive to green light, okay? Cannot perceive colors in low light. So with this, when you are in a dark room, you can't really see colors well. That is normal, okay? Green is the color that you should be able to see. So if you look at those, the Navy SEALs, when they're going in and doing a storm, what color are those goggles, the night vision goggles? Green, right? There's a reason. All right. So rods, not as concentrated over the cones and distributed over the periphery of the retina, okay? Dim objects are best viewed peripherally, best in highlight conditions. So let's take a look. Inefficient. So I don't want you to be confused. So if we're looking at different detail, we need to see those in highlight conditions. So I don't want you to be confused on that, okay? If we're looking at dim objects, they need to be seen peripherally, okay? So inefficiency of process, so very large discrepancies between the number of emitted X-ray photons and the number of light photons that ultimately strike the retina. Okay, so more X-ray photons used in creating image compared to the number of light photons striking the retina to view. X-rays to light conversion for vision is extremely inefficient. Everything we do is inefficient. Have you figured that out yet? All right. So threshold detection, a visual phenomenon associated with viewing extremely small objects, okay? It's dependent on resolving power of the total imaging system and must minimize noise to increase the detection. So if there's a lot of noise, we're going to miss really small objects. So the boundary effect. Okay, so this is due to difficulty in seeing contrast differences that are far apart. So if objects are close together, only approximately about 2% difference is needed. Okay, if the objects are far apart, we're looking at a 20% difference in order for us to see the difference. Isn't that crazy? So higher image contrast can lessen boundary effect. The Mach effect, so neurologic basis for boundary effect. So some situations prevent neurologic impulses from being transmitted by the retina. Bright light is an example due to retinal bleaching. So retinal bleaching is where you're flooded with bright light, okay? So occurs when the eye perceives a visual contrast boundary, and changes in radiographic density can cause a change in neural signals sent to the brain from the retina. Let's look at edge enhancement. So compresses the grayscale, okay, makes the boundary more distinct. Look at the left side of the step wedge versus going to the right. So as you can see, the shades are getting darker, 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 okay? And this visual illusion can cause misrepresentation or misperception on an image, okay? So, eye motion. Moving eyes while viewing image improves contrast perception. So the photosensitive cells of the retina reach saturation point quickly. So the integration time is 0.2, okay, seconds. So what you want to do is constantly scan the image so that there's not this saturation of the retina. So the retina is constantly refreshing, okay? So moving eyes minimizes optical saturation, okay? Veiling glare. Now we deal with this quite a bit. So when intense light from viewing devices hits eye directly, photoreceptors are overstimulated. So bright light scatters inside the eye. It's similar to the Compton effect. So all these light photons are going all over the place. Okay, so they're scattered everywhere. So it decreases the contrast perception because all we see is white, and reduces or eliminates the image by masking. Okay, so this right here is a fluoro image, and what happens is we have veiling glare here. Okay, so the light is just flooding us. Okay, so what you want to do is collimate that image so that we can see the anatomy. So the anatomy is all there. We just can't see it because all of this scattered white light everywhere. Okay, so that's called veiling glare. So let's talk about viewing distances. So the retina signals to the brain changes when view distance changes. So the radiologist should be moving back and forth to vary this distance, okay? Light intensity varies, and we use the inverse square law. So the light intensity, the inverse square law applies to it also. So it has the spread, right? Because they're waves. Okay, so they're waves of energy. So there is a blind spot right at 9 inches. And did you know that? That's interesting, huh? Radiologists overcome this by varying their viewing distance to improve their visual acuity. So they should be moving back and forth, slowly, so that they can adjust and keep the light intensity changing coming into their eye so that it refreshes. Okay, so let's talk about pattern recognition. So perceptions of combinations that can be classified together to make a diagnosis. RADs need image information presented in a consistent manner, okay? When expected patterns are not recognized, a diagnostic conundrum can exist for a radiologist. So I'm not sure if you're aware, but there's the ABCs of reading a chest, okay? So A, airway. B, bronchus, C, cardiac. So each letter of the alphabet is how they read a chest x-ray. Every single time exactly the same. They check each thing in order. They scan in like a roster pattern, like how a laser light reads a CR plate. So they scan the image in a very methodical way. So if they're looking at the abdomen, they look at the liver, the kidneys, the psoas muscle, the bladder. Then they look at the bony structures. They look at the spine, the ilia, the sacrum. It's very consistent and very methodical. So if something is not right, it throws the radiologist off, and they have to stop, and they have to stand back and figure out what's wrong with the image. Okay, so like if you have a chest x-ray that's semi-obliqued, it's going to throw the radiologist off, and they have to stop, and they're out of their normal pattern recognition. Okay, so controlling image in space. So what we're doing is we're taking this 2D image of a 3D anatomy. So it's a challenge for us. So we need to position the area of interest so the image quality will be the best, right? Start by mentally visualizing the object of interest floating inside the body. So where's the heart inside the body? Where's the liver inside the body? Where's the bladder inside the body? And figure out how you're going to position that, okay? Superimposition of anatomical structures is a huge challenge for all of us, for non-radiologists, okay? Now the radiologist is able to, they have the trained eye to be able to see these in a 2D image in a 3D space, okay? So an art and a skill to manipulate the object to the correct position. So how is the object orientated to the beam and the IR? Okay, having an understanding of cross-sectional anatomy can really help with your concept of an image in space. Okay, so finding that heart in there. So thinking in 3D. So effective positioning skills is dependent on the knowledge of the location of the structures, the shape of the structures, the relationship of the structure to one another also. Okay, that's really important. And certain structures can be manipulated to demonstrate areas of interest. So positioning is intended to de-superimpose the anatomy. So you don't want the anatomy superimposed, you want it free from superimposition. So de-superimpose, okay? Kind of a weird word, but there you go. So we're going 3D to 2D. So a single radiographic image can only display 2 of 3 dimensions. So we're aware of that. Conventional radiographic images miss depth. So we can't see how deep they are within the body. They're all compressed together, right? So we need orthogonal images taken to provide a 3D perspective. So 2 separate images taken at right angles, right? So we need at least 2 images 90 degrees from each other in order to see that 3D space. So there you go. There's your 2 90-degree angles and the dimensional views, anterior, posterior, medial, lateral, superior to inferior, okay? So this is part of the job where it's an art and a science, okay? You need to be creative. You need to look at different patients as a challenge and manipulate the patient so that you can get the images needed by the radiologist. Now, this doesn't happen overnight, so don't stress yourself out trying to figure out how to see the anatomy in a 3D when it's a 2D image, okay? So lots of fun, lots to learn. So there are other things within, radiologists. So there's artistic radiography, which is there's an art to it. Okay, so you can make it look like a 3D when it's a 2D. There's also artists that draw things. If you guys get your ASRT magazines, you can see all the art rendering. So it's part of this art that some artists do, train the radiologist to find detail, to look beyond the 2D image into a 3D. So some of it's really interesting. So you read about it in your Carlton book. It's interesting. Non-destructive testing. This is something that we do usually in industry. We look at like the integrity of metal for airplanes. We look at welding seals, that kind of stuff. Kind of interesting. Biological research, of course. Veterinary, of course. Forensic is a really cool area if you're interested and fascinated by forensic radiology or forensic sciences. You can actually work at the morgue and help find cause of death. Pretty cool. And archaeological radiology, so pretty cool. There's also radiology where we image the plates, the earth plates, kind of cool for plate tectonics. There's also a huge C-arm that scans all the shipping cargo. So there's all kinds of stuff that we do within radiology that's pretty cool. So I didn't really go into it because I'm not going to test you on it. It's just an interesting read if you're interested in something else within radiology. So that's your PowerPoint.